Hi, I'm Dr. Tobin, and today we're going to discuss Quervein's Tenosynovitis. It's one of a number of tendinitis cases that I'll see in the office. And in this one, we have patients that present with pain on the radial or the thumb side of the wrist. It involves two specific extensor tendons, and patients with this will experience pain when they open a door, or maybe they're trying to take a tight lid off a jar. All right, well, there are certain diagnostic maneuvers, and one of these is known as Finkelstein's maneuver for this. And you have the patient put the thumb in the palm, wrap the fingers around it, extend the elbow, and drop the wrist down on the little finger side like you can see me doing. If a person has this, they'll have substantial pain right in this area. So what do? Once the diagnosis is made, we're going to try an injection of a steroid right into that certain area. Then we'll try non-steroidal anti-inflammatory drugs and also a splint. After 4 weeks or so, we'll know if that works. And in some cases, we actually do have to go to the operating room. Let's go to a diagram, and I'll point out some of the anatomical features. And maybe later we can see an operation. Thanks. Here we are with the diagram for Quervein's Tenosynovitis. As I said before, it involves two extensor tendons for the thumb. In this case, it's the abductor pollicis longus and the extensor pollicis brevis tendons. They pass underneath this strap-like structure called the extensor retinaculum. And it's that repeated passing back and forth that can sometimes become almost friction-like, and you get inflammation, swelling, and pain. So what we have to do is, in the case of conservative management, apply an injection right in here to reduce that inflammation. And if that doesn't work, we'll just go ahead and make an incision and release that extensor retinaculum structure. Let's go to the operating room and you can see how it's done. Hi, here we are in the operating room, and as I've already explained to you what Quervein's Tenosynovitis is from the diagram, we're getting ready to do one of the operations on a patient that has failed conservative management. We've injected her and we've had her in a thumb spica splint for 3 weeks. In addition, she's had a non-steroidal anti-inflammatories administered. So, here we go. All right, we've got the incision made, and with the help of my assistant Lana, we will demonstrate what's going on. Here are the tendons involved in the first dorsal compartment. There's a couple of them here, as I showed you on the diagram. Now, right below the retractor here, we have a branch of the superficial radial nerve that we want to keep out of harm's way. And this is one of those. And with the tip of my scissors, we're actually going into this very thickened area, which is probably 2 or 3 times as thick as what is normal. And we're getting ready to incise that to release the pressure and the inflammation on these tendons. Now you can see on cut section how thick this first dorsal compartment was. As I said just a moment ago, it's 2 or 3 times the normal thickness, and I hope you can see that. 2 tendons are involved, the extensor pollicis brevis, and that's this one that we see extending the metacarpal phalangeal joint of the thumb, and the abductor pollicis longus, the one that allows you to pick your thumb up off the table when your hand is flat. The patient has had the operation done under what we call an IV regional anesthetic. She's awake, but her arm is numb, and in order to make sure that we didn't have any bleeding, we numbed her up with the long-acting local anesthetic. We released the tourniquet and then stopped any minor bleeding that was going on, and now we have her repaired with what we call a subcuticular suture. There are no stitches to remove. So we're going to get her dressed up, and I'm sure she's going to do very well.